Hello, everyone. I will be discussing the assessment, nursing interventions, and considerations for a patient with an exacerbation of COPD. With patient David Nazal presenting to the emergency department with acute exacerbation of COPD, the circumstances warrant immediate identification of treatable traits following an assessment paradigm as outlined by the recommendations published by the Lung Foundation Australia. An A to E assessment is a multifaceted assessment that can help to quickly identify David's clinical status and assist clinicians in prioritizing the identified issues that require immediate intervention and commence an action plan tailored to David. This assessment shares priorities with the treatable traits paradigm recommended by the Lung Foundation Australia in their 2021 publication for COPD. Starting with airway, as David's has been observed to be fully patent and without obstruction, allows us to address our primary concern, his breathing, from which we can observe and fully recognize the severity of his respiratory distress as we take note of his elevated respiratory rate of 30 breaths per minute, blood oxygen saturation level of 78% on room air, as well as his short, shallow respirations, even at rest. We can also note our observation of his tripod seating position, barrel chest, and use of his accessory muscles. From assessing David's breathing, it is apparent from the beginning that his blood oxygen saturation requires immediate attention, as it is far below the acceptable limit and must be addressed as a first priority, as it has exceeded the range for which an emergency response is warranted, along with his respiratory rate, which is also in range for a clinical review from a medical officer. David's circulatory system is under great strain, with his pulse rate at 128 beats per minute, denoting sinus tachycardia. His blood pressure is also elevated, measuring 168 over 85 millimeters of mercury. These measurements warrant further investigation of those abnormalities through an electrocardiogram. Moving on to disability, David's GCS is also below baseline, scoring 14 out of 15, as he is not fully orientated to time, place, or person. This indicates his cognition has declined while also having become very distressed, further indicating for urgency, as his condition is affecting additional body systems. Finally, with exposure, he is experiencing a fever for which he would require frequent monitoring in case of further deterioration. With David's current oxygen saturation standing at 78% on room air, he is only just above a proposed safe lower limit of hypoxemia in the context of his COPD, beneath which he would face imminent death. The Thoracic Society of Australia and New Zealand, TSANZ guidelines recommend non-invasive ventilation, NIV, to maintain SpO2 between an 88 to 92% target range for COPD patients to prevent hypercapnic respiratory failure. NIV can help to alleviate David's respiratory distress by relieving the respiratory and accessory muscles that have been overworking and increase cellular ventilation in his lungs. It can also help to adjust cardiac load and thereby reduce systemic oxygen demand, as well as address his blood pressure. A nursing spirometry assessment is comprehensively the best method in determining the severity of David's COPD, especially considering his increased sputum production. His forced expiratory volume in 1 second, FEV1, would be expected to accurately reflect his severe impairment to airflow. This is especially compared to his previous evaluations, as well as his difficulty with achieving sufficient relief from his respiratory distress with his puffer, warranting further investigation and a consultation from a specialist. David's COVID-19 infection has led to an imbalance of enzymes in David's lung cells, resulting in the constriction of his blood vessels as observable with David's elevated heart rate of 128 beats per minute and blood pressure of 168 systolic. An electrocardiogram, ECG, measures the electrical signals traveling around the cardiovascular system in different locations to inform clinicians about heart activity. An ECG assessment would be critical in monitoring these changes and helping to screen for arrhythmia and disease. Bronchodilators are usually the first line of defense against COPD. Typically administered as metered-dose inhalers, MDIs, with spacers, but also as nebules for administration via nebulizer masks. Salbutamol works to help relax and open the airways and help relieve respiratory distress. Ipratropium can work in combination with salbutamol to achieve greater relief of David's respiratory distress than if administered in isolation. These medications can be delivered through an NIV device to further improve his expiratory volume. And as David is to receive oxygen therapy, salbutamol, ipratropium, prednisolone, azithromycin, and Paxlovid, clinicians should assess his current condition and anticipate the effects of treatment for which David should be continually monitored. It is important to consider David's appearance, his oxygen saturation levels to accurately measure the dysfunction of his respiratory system and inform the delivery of supplemental oxygen. The TSA and Z recommend hypercapnic patients like David to maintain an oxygen saturation level between 88 and 92%. Risks related to its use include hyperoxemia above the suggested limit, which can result in further exacerbation of his hypercapnia. Comprehensive assessment and monitoring of David's airway functionality is essential to determine adequate dosing and delivery of salbutamol, as David's efforts with his MDI have proven inadequate. Pursuing alternative methods should be considered. Clinicians should be wary of polypharmacy, balancing potential benefit and risking side effects such as cardiac issues, neurological conditions, and gastrointestinal problems, with overuse having been associated with lung, heart, and kidney dysfunction. In the delivery of ipratropium, it is important to find out if David has any pre-existing conditions that would exacerbate with its administration, such as retention and constipation to monitor, as well as prostatic hyperplasia or bladder neck obstruction. While administering, there may be observable reactions to the medications, and correct technique should be taught and utilized. Side effects include headache, dizziness, cardiovascular issues, gastrointestinal issues, respiratory problems, and urinary retention. Prednisolone can suppress the immune response, and so David requires additional measures of supervision, as signs of deterioration may appear, if at all, less prominent. His mental status, vital signs, and bowel function should be closely monitored for alterations while receiving treatment, and especially once completed for withdrawal or excessive dosing for prolonged periods. David's BGL should be routinely monitored post-commencement, as well as his skin integrity and/or wounds. David may begin to feel nauseous and vomit, as well as face reduced appetite. Before the treating team consider ordering azithromycin, they should consider David's current medication regimen and whether there are major risks of conflict. He should be observed for signs of other existing infections or pathogens, such as fungi, that are unaffected by antibiotics like azithromycin. He should be monitored for hypersensitivity or allergic reactions, as well as gastrointestinal issues, and his vital signs should be monitored prior and upon commencement of treatment. In terms of side effects, the most common are diarrhea, pain, and nausea, with others less common. Paxlovid treatment should be commenced immediately after COVID-19 is detected and diagnosed. David should be monitored for signs of renal and hepatic impairment, as it is contraindicated if the impairments were severe. It is necessary to ensure the treating team have considered potential conflicts with any of David's current and recently discontinued medications, such as CYP3A inducers. He requires observations throughout the treatment process for any signs of hypersensitivity and hepatotoxicity. Adverse effects include altered sense of taste and diarrhea. I have now covered the assessment, nursing interventions, and considerations for acute exacerbation of COPD, and we have reached the conclusion. Thank you.